Okay, let us continue. Everybody hearing me?
Yes, sir.
Sir.
Yes, sir.
All right. So we are now going into distributive shock. We have completed shocks associated with the pump. We have looked at cardiogenic shock, which is direct damage to the heart. And we have looked at obstructive shock, which there is a problem causing indirect obstruction of the heart. And the three conditions that can cause that is hypotension, pneumothorax, cardiac tamponade, pulmonary embolism. Now let's look at distributive shock. Now the vessels, distributive shock is associated with the vessels. So we need good vessel tone in order to function in our daily lives, right? So our blood vessels are never fully open or fully closed or constricted. They adjust in size based on the activities that we're carrying out. And this is controlled by the capillary sphincters, which are stimulated by the autonomic nervous system. Now, when we have good vessel tone, we're able to pump blood to the core organs and the peripheral areas. It means we have a good, adequate blood pressure, right, to meet the body's demands. Now, one of the things that can occur is we can get vasoconstriction. When there is vasoconstriction, the diameter of the blood vessel decreases, and that will result in increased pressure, right, inside of the blood vessel. So the pressure can increase, or it can be so severe that it cuts off the blood flow completely. That's vasoconstriction. When a patient goes into distributive shock, the problem is ultimately widespread vasodilation. So regardless of the cause, but for the various types of distributive shock, the primary problem will always be the blood vessels are too open. And if the blood vessels are wide open or too dilated, the pressure inside of the blood vessels will fall. If the pressure inside of the blood vessels is low, we cannot get good cardiac output. So this is referred to as distributive shock. Now we have 4 types of distributive shock. You have septic shock, anaphylactic shock, neurogenic, and psychogenic shock. Right? So let me go back to the slide. The easiest one to learn is psychogenic, because psychogenic shock is actually fainting or syncope. That's what it is. It's actually fainting or syncope. And what happens in psychogenic shock is, for a temporary moment, for a brief moment, the blood vessels that supply the brain, the cerebral blood vessels, are too dilated, resulting in a drop of flow or decreased blood flow to the brain. Let me go to psychogenic first. I don't want to talk about septic yet. All right, so psychogenic shock, right, is fainting or syncope. This is the first one we're going to look at. So it's caused by a sudden reaction of the nervous system. produces temporary generalized vascular dilation, results in fainting or syncope. So for a brief moment, the blood vessels that supply the brain open up too much. There's not enough blood going to the brain, so the patient faints or passes out. As soon as that blood flow is returned, the patient wakes up. Now, it's temporary, but what are some of the things that I would need to consider if I have a patient that complains of fainting? Miss Jackson, you have a patient that complains of fainting. Is there anything you would want to think about or ask this patient? Come forward, Miss Jackson, come forward.
Well, sir, personally, the person is fainting a lot. They're complaining of fainting. You'd want to check for like nervous problems.
You want to check for nervous problem. Is there anything you would want to ask the patient?
To ask.
Yeah. Nothing come to mind?
No, sir.
All right. Miss Johnson, you have a patient that complained of fainting. That was the call that you get when you arrive on scene. What are some of the things that you would want to consider or ask the patient?
I would want to know if this is something that occur often, or is
Yes.
it just a one-time thing? Is it the first time it's
Okay.
happening?
That's a good question to ask. Anything else?
Did they get any traumatic news or anything like that while they fainted?
Good. Good. So that is very important. The position that the patient faint in, right? Was this patient in a couch? Was this patient lying in bed? Was this patient on top of a ladder, right? So we have to consider the possibility of trauma if the patient was standing or at a height when they faint. If they're in a bed or a couch, then we have to start thinking about some medical issue going on. So the position that the patient faint in is going to be very important, right? Now, it is a temporary event. It is a temporary event. They can have recurrent fainting episodes. If that is happening, then there is another problem, right? There's something else wrong with the patient. So that is psychogenic shock. It's very straightforward. Temporary dilation of the blood vessels that supply the brain. Patient passes out. Once the blood flow returns, the patient wakes up. That's it. That's psychogenic shock. Now, where was I? Sorry. Let me backtrack. I'm moving too fast. Some causes are serious and others are not. Life-threatening causes include irregular heartbeat and brain aneurysm. Non-life-threatening events include receipt of bad news or experiencing fear or unpleasant sights such as blood, right? And that is psychogenic. Now let's look at neurogenic. All right, so let's look at neurogenic shock. All right, now neurogenic shock is sometimes confused with psychogenic shock. Now the difference between neurogenic shock and psychogenic is neurogenic shock is caused from an injury to the spinal cord. So this patient gets a spinal injury, but where that injury has occurred, or where that spinal complication has occurred, it has cut off the sympathetic stimulation, right? So where the injury is, the sympathetic stimulation has been cut off. And if there is no sympathetic stimulation to the blood vessels, the capillary sphincters cannot maintain vessel tone. So when that sympathetic stimulation is cut off, the blood vessels open up, right? They vasodilate. And as a result of that, the pressure inside of the blood vessels fall, right? Now, neurogenic shock is very unique because it cuts off the sympathetic stimulation, the injury or the complication. This patient will have limited or no sympathetic signs and symptoms. What do I mean by that? You're not going to see cool, clammy skin for this patient. You're not going to see tachycardia for this patient. And if you see tachycardia, it's not going to last for very long because there is no sympathetic stimulation, right? So that is what is unique to neurogenic shock. So neurogenic shock, usually the result of high spinal cord injury. Causes include brain conditions, tumors, pressure on the spinal cord, spina bifida. Neurogenic shock, muscles in the blood vessel walls are cut off from the nerve impulses that cause them to contract. Right? And that's it in a nutshell. So the problem is in neurogenic shock, ultimately widespread vasodilation. But what is the cause? It is a injury or complication of the spinal cord that cuts off the sympathetic stimulation. This is the portion of the nervous system that controls the capillary sphincters. If they are not being controlled, the vessels open up and the pressure inside of the vessels fall. This results in distributive shock. Now let's look at anaphylactic shock. Anaphylactic shock is a severe allergic reaction, right? Now, for us to have an allergic reaction, the typical presentation is we have to be sensitized to the allergen, right? So the allergen will enter the body through inhalation, ingestion, absorption, and injection, right? Now, when an allergen enters the body and the body is not able to recognize it, what the body does is send cells to the area where this allergen is and record the structure of it, right? So the body is going to record the structure and tell this invader to leave, and then the body is going to create antibodies and store them, right? Now, at that point where the allergen enters the first time and the body records its structure and tell it to leave, that's where we become sensitized, right? There is no visible reaction, the body is just sensitized. If this allergen returns, then the antibody will activate and we get an allergic reaction, right? Now, one of the things that occurs when we get an allergic reaction is the body produces histamine. And what histamine does is it dilates your blood vessels, which makes sense, right? Because when there is a anaphylactic or allergic reaction, white cells need to deal with the situation, white blood cells. And for the white cells to get to the area, we must have vasodilation, right? Because they move to wherever the problem is. So when histamine is produced, the blood vessels open up and they become more permeable, right? Now, at a local level, that's fine. not too bad at a local level. You might get a little itching at the skin, area local, you might see some hives going on there, but as soon as you take the DPH, you feel better, right? Now, if this reaction becomes systemic, right, meaning it gets into the bloodstream and becomes systemic, when histamine is circulated systemically within the body, it will cause your ear passage to lock up. It's going to constrict the ear passage, and it will dilate all of the blood vessels. So the patient will get vasodilation, and if the blood vessels are fully dilated, the pressure inside of the blood vessels will fall. So with anaphylactic shock, two things are occurring that are serious problems for the patient. One, the patient cannot breathe properly because there is constriction of the ear passage. Two, the blood vessels are so dilated that the blood pressure drops. So there is a circulatory problem and there is a breathing problem, right? And the only way this can be corrected is by giving the patient adrenaline or epinephrine, right? So DPH is for mild allergic reactions. Adrenaline or epinephrine is for anaphylactic shock. This is the patient that cannot breathe and the blood vessels are too dilated. So anaphylactic shock occurs when a person reacts violently to a substance to which he or she has been sensitized. Sensitization means becoming sensitive to a substance that did not initially cause a reaction. Each subsequent exposure tends to produce more severe reactions. Four categories of exposure include injection, tetanus, antitoxin, penicillin, stings, wasps, bees, hornets, ants, ingestion, fish, shellfish, nuts, eggs, medication, inhalation, dust, pollen, mold. Develops within minutes or even seconds of contact with substance. Second phase reaction can occur 1 to 8 hours after the initial reaction. Signs are very distinct. Cyanosis, and if you see cyanosis in a patient with anaphylactic shock, they are not doing well, right? A patient in anaphylactic shock with cyanosis is in bad shape. Make sure you pay very close attention to this table that outlines the signs and symptoms of anaphylactic shock for the skin, the circulatory system, and the respiratory system and other areas. Very important table, table 12-2. All right, so that's anaphylactic shock. Now let's look at the final one, the final distributive shock is sepsis. All right. So distributive shock results from widespread dilation of small arterioles, small venules, or both. The circulating blood volume pulls in the expanded vascular beds, and then tissue perfusion decreases. So again, the ultimate problem with distributive shock is widespread vasodilation. However, you must be able to determine what is causing it. Is it an infection? Is it a allergic reaction? Is it simply fainting? Is it from a spinal complication or a spinal injury? You must be able to determine the cause, right? Now, the final distributive shock is sepsis. Now, when a patient gets septic shock, a bacteria, so this is usually from a patient, this is usually a patient recovering from an illness, right? So this patient had some medical issue. They are recovering. The body is in a vulnerable state, right? The environment that they're in is not sterile, and a bacteria enters the body. So a bacteria enters the body. Now, if this bacteria enters the bloodstream, it will eventually become systemic, right? So the bacteria becomes systemic. When the bacteria becomes systemic, it has to multiply, right? So it's gonna have to multiply. And the body is going to try and deal with the bacteria. Now, again, the blood cells responsible for that would be your white blood cells. And how the body will get blood cells to the area is it will vasodilate the blood vessels so that the white blood cells can move and the blood vessels become more permeable. The other thing that the body will do if there is a bacteria in the blood is it will increase the temperature of the body, right? And that is the body's way of fighting the bacteria. So when we start to develop a fever, the body is actually trying to restrict the bacteria from multiplying, and the heat can also break down the bacteria, right? So the patient will develop a fever. Now, one of the things that the bacteria will do is it will start to form pockets in the small blood vessels. So little pockets start to form, right? So we have massive vasodilation, right? When we talk about distributive shock, with the exception of psychogenic shock, it's massive vasodilation. That means the blood vessels that are going to the core organs are dilated, and the blood vessels that are going to the peripheral areas are dilated. So it's massive vasodilation, right? So that is what is occurring in the septic patient. Now, because it's a bacteria and it creates a septic infection within the bloodstream that results in widespread vasodilation, it is referred to as septic shock, right? This patient will need most of the care that they will need or they will benefit from is in the hospital setting, right? Gonna need fluids. Their urine output needs to be monitored. They're gonna need antibiotics, right? There's not much we can do for these patients outside of maintaining airway, breathing, and circulation in the field. If the patient does not recover, eventually they will go into organ failure, right? So the organs will start to shut down. Now, septic shock is very common in Jamaica, very common, right? Especially in the old age home or nursing homes. I've seen quite a few cases in the hospital setting. It's common in females that attempt abortion, right? Or have incomplete abortion. So it is common here. So septic shock occurs as a result of severe infections in which toxins are generated by bacteria or by infected body tissues. Toxins damage vessel walls, causing increased cellular permeability. Vessel walls leak and are unable to contract well. So we get widespread vasodilation because of the bacterial damage. Widespread dilation of the vessels in combination with plasma loss through the vessel walls results in septic shock, right? And that's your distributive shocks. Now let's look at hypovolemic shock. So that's the last one. Not the last one for the end of the chapter, just the last shock based on the perfusion triangle. And it's the most straightforward one. right? So we have looked at cardiogenic shock, obstructive shock. We have looked at distributive shock, and now we will look at hypovolemic shock. And that can be in the form of excessive blood loss, or it can be in the form of plasma loss. So, result of an inadequate amount of fluid or volume in the circulatory system, hemorrhagic causes and non-hemorrhagic causes occur with severe thermal burns. We will get intravascular plasma loss, so the plasma is lost. With excessive diarrhea and vomiting, it's also the plasma that is lost. Dehydration, the loss of water or fluid from the body tissues, can cause or aggravate shock, and that will occur with severe vomiting and or diarrhea, right? And how that occurs really is what is happening with vomiting and diarrhea. This is a blood vessel, right? So this is a blood vessel. These are the cells within the blood vessel, right? So that's a blood vessel. We have cells in the blood vessels. You have fluid in the blood vessels, and this is called intravascular fluid. We have fluid between the cells, and this is called interstitial fluid. And we have fluid inside the cell, right? We have fluid inside the cell, and that is called intracellular fluid. Now, when a patient is vomiting excessively or have diarrhea, the fluid that is inside of the blood vessel, the plasma portion of that fluid is depleted, right? So the plasma portion of the fluid is depleted. There is a drop in the intravascular fluid. Now, what the body will do, which makes sense, if there is a drop in the intravascular fluid, it means that there will be a deficit in the blood volume, because plasma is a part of the blood volume, right? So we would have less blood going to the heart, less blood leaving the heart, and that's how we get the hypovolemic shock. Now, what the body does to compensate for that fluid deficit is the fluid that is between the cells will move into that space to fill it. So this fluid starts to move and fill that space. And when the fluid that is between the cells, when that fluid shifts, the fluid that is inside of the cell will move to fill this space. So the fluid that is inside the cell shifts out to fill this space. That fluid is moving out. Now, as that occurs, the cell shrinks in size. And when the cell shrinks, that's when the cell becomes dehydrated, right? So that's how we get dehydration of the cell. So again, if the fluid in the intravascular space is lost through severe vomiting or diarrhea, that's the plasma. Plasma is a part of the blood volume. If less blood is going to the heart, less blood is being pumped out of the heart. So there's a fluid deficit. So the body's try to compensate for that fluid deficit by shifting the fluid that is between the cells into the intravascular space. And as that fluid in the interstitial space or between the cells is depleted, then fluid will now shift from out of the cell and fill the spaces between the cell. And majority of the fluid inside of the body is inside of the cell. And once the fluid inside of the cell is depleted, it shrinks in size. That is dehydration. That's how we get dehydration from hypovolemic shock, right? And that's it for hypovolemic shock. So if it's excessive blood loss or hemorrhaging, the fluid deficit is from the blood loss, right? If it's excessive diarrhea or vomiting, the fluid deficit is from plasma loss. Now, respiratory insufficiency. A patient with severe chest injury may be unable to breathe in an adequate amount of oxygen. An insufficient concentration of oxygen in the blood can produce a life-threatening situation as rapidly as vascular causes of shock. So if there is a problem with the respiratory system, it can also lead to cardiovascular collapse or shock, hypoperfusion. Anemia is an abnormally low number of red blood cells. Hypoxia occurs because blood is unable to deliver adequate amount of oxygen to the tissues. Now, certain types of poisoning may affect the ability of cells to metabolize or carry oxygen. So carbon monoxide poisoning is one, right? So once it's in the body, the red blood cell will bind to it more than oxygen. So there is a higher affinity, right? Over 200 times more than oxygen. So once carbon monoxide is in the body, it will bind to the cells. The cells cannot get the oxygen, and then we have a respiratory insufficiency. Cyanide is similar in how it works, where it affects the oxygen ability to bind to the red blood cell, and it results in respiratory insufficiency, right? Cyanide poisoning was used to kill the people in Jonestown. You can research that on YouTube or Google, right? Almost 1,000 people died from cyanide poisoning. Jim Jones massacre. Check it out. Now, the progression of shock. The stages in the progression of shock, you have the compensated shock and decompensated, and you have irreversible. Now, in the compensated stage of shock, this is the early stage when the body can still compensate for blood loss. Decompensated shock is the late stage. And one of the key things that occur in the decompensating stage of shock is the blood pressure will fall. No way to assess when effects are irreversible. Must recognize and treat shock early. So you need to be looking for the signs and symptoms of shock, and if they are present, start treating early. Right? And you can zoom in on your chart to see the signs of compensated shock and decompensated. Now in the compensating phase, things tend to go up, right? Things tend to go up. In the decompensating stage, things start to decline and you start to lose certain pulses, like peripheral pulses start to become very weak or they disappear completely, right? Blood pressure going down. These are signs of decompensating shock. Blood pressure may be the last measurable factor to change in shock. When a drop in blood pressure is evident, shock is well developed, particularly true in infants and children. Expect shock in many emergency medical situations. All right, so also expect shock if a patient has any of the following conditions: multiple severe fractures, abdominal or chest injury, spinal injury, a severe infection, a major heart attack, anaphylaxis. So let's go through the patient assessment now. So the first thing we need to do is ensure that the scene is safe. We take the necessary standard precautions for ourselves and our partners, right? We consider the mechanism of injury or nature of illness. We determine how many patients we have and whether or not we need additional resources. So be alert for potential hazards to your safety. Use gloves and eye protection for trauma scenes or if bleeding is suspected. In incidents involving violence, make sure the police are on scene. Then once we complete our scene size up, the next phase is the primary assessment. The first thing we do is form a general impression of the patient and the environment. So you're looking at your patient, you're considering their age, position, level of distress, and race, right? You look at the environment for clues as to what could have occurred or what happened to the patient. After a general impression, the next step is to ascertain the patient's level of consciousness using the AVPU. Then we will assess and manage airway, assess and manage breathing, assess and manage circulation. Then we will determine whether the patient requires a rapid scan or a focus, and whether or not we have a load and go patient or a stay and play patient. And the purpose of the primary assessment is to identify and manage immediate and potential life threats. So primary assessment, perform a rapid exam, determine the level of consciousness, identify and manage life-threatening concerns, determine priority of the patient and transport, right? Provide high-flow oxygen to assist in perfusion. For hypoperfusion, treat aggressively and rapid transport. Request advanced life support as needed. You form a general impression of the patient and the environment. Assess airway, make sure it is patent. Assess breathing, determine if you need to supplement it or provide positive pressure ventilation. An increased respiratory rate is often an early sign of impending shock. Assess the patient's circulatory status. A rapid pulse suggests compensated shock, unless the patient have what? Neurogenic shock. So if the patient has neurogenic shock, they won't have a rapid pulse because there is no sympathetic stimulation. In shock or compensated shock, the skin may be cool, clammy, or ashen. Pale skin means poor circulation. Blue skin or cyanosis means poor oxygenation. Mottled skin where it's patchy means the blood is not circulating or the patient is starting to go into organ failure. Assess for and identify any life-threatening bleeding and treat it at once. Determine if the patient is a high priority, if ALS is needed, and which facility to transport to. Trauma patients with shock or a suspicious MOI generally should go to a trauma center. After we have completed the primary assessment, the next phase is history taking. We will ask the patient question about the chief complaint. We will obtain a sample history. If there is pain, we will obtain the OPQRST, right? This information, we can get it directly from the patient, family members, bystanders, or we can look at the scene and the patient for clues. In our secondary assessment, this is where we will do our baseline vital signs or recorded vital signs. This is where we will use our monitoring devices. We will either do a detailed systematic head to toe or a focus assessment, right? And the purpose of the secondary assessment is to look for things that may have been overlooked because we were focused on the primary assessment, or we're looking for things that develop slowly, right? And your vitals that you want pupil reaction, You want respiratory rate with description, pulse rate with description, skin condition, temperature, hydration, cap refill, pulse oximetry, end-tidal CO2 if it's a part of your organization, blood pressure, right? By the time you get to this stage, you should know what your patient's GCS is, right? And I always tell my students that once you complete your primary assessment, you should know what your patient's GCS is. Then we get to the reassessment phase. In the reassessment phase, we are repeating the primary assessment. We are repeating the primary assessment. We're looking at our interventions. Did they work? What do we need to change? What do we need to improve? Right? We reevaluate the chief complaint, reevaluate the ABCs, and we document and we communicate. Documentation, communication. And it is what the patient tell you, what you observed, what you did based on your observation, how did the patient respond, and your method of transportation. To determine what interventions are needed, focus on supporting the cardiovascular system, treat for shock early and aggressively by providing oxygen, keep the patient warm, right? All right, now emergency care for the different types of shock. As soon as you recognize shock, begin treatment. Take standard precautions. Always manage obvious bleeding quickly, right? Control all obvious life-threatening bleeding. Make sure that the patient's airway is patent. Maintain manual inline stabilization if it is necessary and check breathing and pulse. Comfort, calm, and reassure the patient. Never allow the patient to eat or drink anything prior to being evaluated by a physician. If spinal immobilization is indicated, splint the patient on a backboard. But based on the new protocols, we will not keep the patient on the spine board. You will use the spine board to move the patient to your unit. Once the patient is on the stretcher, remove the patient from the spine board. And I said remove the patient from the spine board. I didn't say remove the C column. Provide oxygen and monitor the patient's breathing. Place blankets under and over the patient to keep the patient warm. Consider the need for ALS, especially if you suspect a tension pneumothorax or a cardiac tamponade or a patient with massive fluid deficit in some type of distributive shock where they will need IV access and fluid resuscitation and possible vasopressors. Do not give the patient anything by mouth, no matter how urgently you are asked. Accurately record the patient's vital signs. Accurately, don't make up no vital signs. Check them, right? Every 5 minutes throughout treatment and transport. All right, so now let's look at this management for the specific shocks. Cardiogenic shock. Patient cannot generate the power to pump blood throughout the circulatory system. Chronic lung disease will aggravate cardiogenic shock. Patients in cardiogenic shock should not receive nitroglycerin. And nitroglycerin is a medication that is given for chest pain, right? But if the blood pressure is too low, you cannot give nitroglycerin because it's a vasodilator. Patients usually have low blood pressure, weak, irregular pulse. Anytime you have a patient with an irregular pulse, something is wrong with their, well, let me not say something is wrong with their heart. They have an irregular heart rhythm, right? Or abnormal heart rhythm. Cyanosis about the lips underneath the fingernails, anxiety, nausea. Place the patient in a position that ease breathing as you give high flow oxygen. Assist ventilation if there is signs of respiratory failure or arrest. Provide transport. Consider meeting ALS en route to the hospital. Provide calm reassurance to a patient with a suspected heart attack. For the cardiac tamponade, which is obstructive shock, increasing cardiac output is the priority. Apply high-flow oxygen. Surgery is the only definitive treatment. Pericardiocentesis uses a needle to withdraw blood. Advanced skill, rarely performed in the field. For tension pneumothorax, apply high-flow oxygen to prevent hypoxia. Chest decompression is required, and this is a paramedic skill. Ask for ALS early in call if available, but do not delay transport. And remember, if you see a deviated trachea in a patient with a suspected collapsed lungs, they do not have a lot of time to live. So when you have a patient involved in any type of activity or accident that involve blunt force trauma to the chest, always listen to the patient's lung sound, right? So you can hear diminished lung sounds before the trachea shifts, right? So always get accustomed to listening to the lungs once there is suspected trauma to the chest or abdomen. Treating septic shock, hospital management is required. Use standard precautions and transport. Administer high-flow oxygen. Ventilatory support may be necessary. Use blankets to conserve body heat. Use sepsis steam if available. Right now, a fever is associated with sepsis, but keep in mind that your geriatric population can have sepsis with no fever. So the geriatric patient can have an infection and they don't have any fever. Treating neurogenic shock, you definitely need to consider spinal motion restriction procedures. For the spinal cord injury patient, use a combination of all known supportive measures. Hospitalization will be required for a long time. Emergency treatment, obtain and maintain a proper airway. Very important. Provide spinal immobilization or motion restriction. Assist inadequate breathing, conserve body heat, ensure the most effective circulation. Transport promptly. And for anaphylactic shock, epinephrine. So once there is complication with breathing from bronchoconstriction and the cardiac output has been compromised due to vasodilation, then epinephrine is the only thing that can reverse that. So epinephrine will open up the air passage and constrict the blood vessels. So it's fixing both problems. Administer epinephrine, promptly transport the patient, provide high flow oxygen and ventilator assistance en route. A mild reaction may worsen suddenly. Consider requesting ALS backup if available. All right, treating psychogenic shock. In an uncomplicated case of fainting, once the patient collapses, circulation to the brain is restored. Psychogenic shock can worsen other types of shock. If the patient falls, check for injuries. If the patient reports being unable to walk after a fall, suspect another problem. Transport the patient promptly, record all initial observations, and try to learn from bystanders. If the patient complained of anything, how long the patient was unconscious, right? These are important questions to find out prior to fainting. What did the patient complain of? How long was the patient unconscious? Treating hypovolemic shock, control all obvious external bleeding. Keep the patient warm, recognize internal bleeding, and provide aggressive support. Secure and maintain an airway and provide respiratory support. Transport as rapidly as possible. Rapid transport. For respiratory insufficiency, secure and maintain the airway. Clear the mouth and throat of obstructions if necessary. Provide ventilations with a BVM. Administer supplemental oxygen. Transport the patient promptly. Now, treating shocks in older patients. Things to consider. The EMT must use caution when caring for older patients. Older patients have more serious complications than younger ones. Illness is not just a part of aging. Many older patients take medications that can hide the signs and symptoms, or it can mimic the signs and symptoms of shock. And that is your shock chapter. So again, it's not as long as patient assessment, it's not as long as airway, but it is just as important because you have to understand the presentation. Do not swat the shock. You need to understand what the shock is doing to the body. And that's how you will approach this particular chapter, right? It is a module, so you will definitely see an exam on shock next week. Now let's go through the questions. So, Ms. Jackson, question 1 is yours.
The term shock is most accurately defined. B, sir.
B as in boy?
Yes, sir.
Mute your mic. B is correct. Mr. Jennings, number 2.
Would the answer be A, sir?
Urticaria. That is correct. Hives. Miss Nesbitt, number 3.
Coming up, sir. B, sir. Weak or absent peripheral pulses.
B as in boy?
D as in dog.
Okay, D is correct. D is correct. Miss Johnson, number 4. Miss Johnson, number 4.
Yes, sir. I'm looking at it.
Okay.
B.
B as in boy. When treating a trauma patient who is in shock, lowest priority should be given to what? And you said B?
Um, or D.
All right. So this is how you're gonna work this one out, right? All right. So what would this patient need for sure? Would the patient need spinal protection? Go ahead, Miss Johnson.
No, they would not.
Of course, the patient would
No.
need spinal protection. If it's a patient with neurogenic shock, you need to secure the spine. And that would be a priority, yes? That's a priority in neurogenic shock management. Would the patient need thermal management? Most patients that go into shock have what? Cool, clammy skin, diaphoresis. We need to maintain the temperature of the skin. That's a priority, right? Keeping the patient warm is a priority. Why? You don't want a shock patient to get cold. That's very bad for a shock patient. You don't want a shock patient to get hypothermic, right? That can lead to the metabolic activity slowing down, and we start to get acidosis and the blood stop moving properly. So thermal management is priority. Notifying the hospital definitely is priority. We have to let them know what we're coming with, right? Splinting a fracture, that's not a priority because you can do a full body splint. So if I have a patient that has a suspected spinal injury and he has a fracture to his right leg below the knee, do I need to stabilize that fracture in the field? Certainly not. I can put that patient on a spine board and stabilize en route to the receiving facility. So the lowest priority would be splinting, right? Splinting would be the lowest priority. And I think my computer is freezing up on me. Great. All right. So I may have to log out and come back. I may have to log out and return. Don't go anywhere now. I'll be back. I will be back like the Terminator, right? I shall return.
Hi guys, did you guys get the pen light? Anybody got their pen light?
Not yet.
If you're in Kingston, there's a place called Scientific Medical Supplies. It's on Mountain View. You can get it there if you're in Kingston. It's just like $400 and something plus tax.
All right, thank you.
Sure.
All right, I am back. You hearing me?
Yes, sir.
All right,
Yes, sir.
all right, all right. So C was the answer. Back to Miss Jackson. Miss Jackson, number 5.
Potential causes of cardiogenic shock include following except C, sir.
Okay, C is correct. Jennings. Go ahead, Jennings. Miss Jackson, mute your mic.
Would the answer be A, sir?
Okay, yes, that's very clear cut. Septic infection, yes. Miss Nesbeth, number 7.
C for tachycardia, sir.
That is correct. So doesn't mean that it cannot happen. It can, but it won't be there for very long because the sympathetic stimulation has been cut off. Good. Sharp. Very sharp. Miss Johnson, this is a critical thinking question. Read it carefully.
Okay, sir.
So look at everything in the patient's presentation and tell me what you suspect.
D, sir.
D as in dog?
Yes, sir.
Okay, that is correct. Miss Jackson, number 9.
Woman presents a generalized rash, facial swelling, and hypotension approximately 10 minutes after being stung by a hornet. Her blood pressure is 70/50 millimeters of mercury, and her heart rate is 120 beats per minute. In addition to high flow oxygen, this patient is in most immediate need of A, sir.
Okay, A is correct. All right, mute that mic. Mute your mic, Miss Jackson. Mr. Jennings, last question.
Answer is A, sir. A, alpha.
Okay, that is correct. Right, so that is your shock chapter. Let me. Yes, Miss Nesbeth.
Sir, is everything okay with Ron?
What do you mean?
I don't see him or hear him today.
Rowan and Miss Dennis are Sabbath persons, so they go to church on a Saturday.
Okay.
That's why they are not here. At least that's what I was told. So you should see him on Tuesday or hear him on Tuesday. All right. Now, I gave you 2 assignments, right? One was to write up your assessment approach for a patient that is responsive but showing signs of good chest rise but having difficulty breathing. So let's tackle one of these now. So this is the scenario. You are called, I think Miss Jackson just got kicked out. You are called to a location. It is reported that there is a young man having difficulty breathing, right? A young man having difficulty breathing. Mr. Jennings, what are
Yes,
the
sir.
things that you would cover in your scene size up? What are the things you would cover in your scene size up?
Well, first thing I would cover is the entry into where my patient is, the exact location, so that I know how I'm getting out. I would look for any obstacles that might cause a problem, especially if we're out
All
on the
right,
stretcher.
so that's safety, full stop.
Okay.
Safety is one. Ms. Nesbitt, what else we're looking for? So we need to make sure that the scene is safe. What else?
We try to determine the mechanism of injury, if it's trauma, or the nature of illness, if it's a medical issue.
Okay, so MOI slash NOI. Now, based on the information that I've given Ms. Nesbitt, is it a NOI or MOI?
It is too early to determine that, sir.
The call that you received said you have a patient that is having difficulty breathing. Are you thinking MOI or NOI at this point?
I'm thinking both, sir.
Okay. All right. So MOI, NOI. Ms. Johnson, what else? Scene safety, mechanism of injury, and nature of illness. What else we need to consider in the scene size?
Well, I need to look at the general area to see who is around and maybe to see if there's any weapon or any
That's
object that
safety.
may cause.
Safety. That's safety. Focus on the components of the scene size. So safety, mechanism of injury. What else we need to do in the scene size?
We need to get a general impression of the individual.
No, general impression is primary assessment. Your general impression is done in your primary assessment. Scene size up is where we're at. We need to make sure that the scene is safe. We need to look at the MOI, NOI, what else? Nothing coming to mind? Miss Johnson? Where Miss Johnson gone?
Here I am.
Come forward. Nothing else coming to mind in the scene size up?
Not at this time, sir.
Okay. Mr. Jennings, back to you. What else? We're in the scene size up.
consider BSI, body substance
Right.
isolations, and
Standard
PPE.
PPE. So we need to take standard precautions. At minimum, gloves. This is how I want you to start thinking. So whenever I ask you a question or you're doing your assessment, you need to know where you are in your assessment. Are you in the scene size up or are you in the primary assessment? I need to know what are the things that must be covered. So we're at safety, MOI, NOI, standard precautions. Ms. Nesbeth, what else?
Well, basically, you would know that the amount of patient now is 1, so you determine the number of patients.
All right, number of patients. Number of patients. All right, so far, indeed, is 1. One last thing now, Miss Johnson. One last thing we need to do.
If there's anybody else that is affected, even though one was reported.
No, that's number of patients you're still telling me about. That would still be number of patient or patients. Nothing else. So it's scene safety. Make sure that the scene is safe for you and your crew members. Consider the MOI or NOI, and so far we're moving towards the NOI based on the information so far. Take the standard precautions at minimum, gloves. We need to be considering mask and goggles. Number of patients currently is 1. We need to consider the need for additional resources. That would be the last one. Additional resources. Now, if I was examining you for a long case practical, each of these components in the scene size up is a mark. So each of them is a mark. And one of them is a critical area. So if you fail to take standard precautions, you would have failed, right? But each of these components give you a mark. And we don't want to lose marks when we're being examined, right? So that would be the scene size up. Scene safe, like nature of illness, difficulty breathing, standard precautions, gloves, considering goggles, mask. 1 patient, we're considering ALS for this patient based on the nature of the call. Now the next phase, which this is where we will stop. We won't go to the history taking today. We're just doing this phase. So the next phase would be primary assessment. Right? So that's the next phase, the primary assessment. Primary assessment. Now, what's the first thing that we do in a primary assessment? Mr. Jennings, first thing, primary.
The first thing you would do is form a general impression of the patient.
Good.
So,
General impression. Now, when you arrive on location, you find a young adult male sitting on the sidewalk. It's a black male. The patient seems to be responsive. The patient is showing signs of obvious difficulty breathing, right? And as you get close to the patient, you can hear audible wheezing. So you can hear wheezing without a stethoscope. That's the patient's general impression. Miss Nesbeth, based on the general impression, what do you suspect? What are your thoughts at this point? Remember, when we form a general impression, we're trying to answer 2 questions. So what are you thinking now? Based on the general impression. Miss Nesbitt, go ahead.
I'm still thinking, sir. Well, based on the general impression, then this will help me to determine the nature of the illness, as well as the proposed treatment that I should give.
Okay, so let me ask you this question then. What is the nature of the illness?
I am thinking that the person is in respiratory distress.
Okay, so the nature of illness is a respiratory problem. You are correct. But remember, our general impression is to answer 2 questions. Does this patient look sick or injured? And if the answer to that question is yes, how sick or injured is this patient? So based on the patient's general impression, does this patient seem to be sick to you, Miss Johnson?
Yes, sir, he is.
All right. How sick do you think this patient is? Is he in good shape or bad shape?
It depends on how he's sitting at the sidewalk and position. For
Okay.
example, if his head is protruded forward and he's sitting in the tripod position, maybe he's in great distress.
Okay. Let me tell you in presentation again. Adult male sitting on the sidewalk seems to be responsive, showing signs of obvious difficulty breathing. And as you get closer to the patient, you can hear audible wheezing. And he is tripoding. How sick do you think this patient is, Miss Johnson?
Sir?
How sick is he to you? Is he in good shape? Is he in bad shape?
Sir, as an asthmatic, he would be in bad shape, sir.
We don't know if he's an asthmatic yet. Okay?
Okay.
We don't know that yet. We just know him having a respiratory problem. Don't jump the gun, right? There are numerous conditions that can cause wheezing. All right. So he's not in good shape, right? He's not in good shape. He's showing obvious signs of breathing difficulty. So his breathing is labored, and you can hear wheezing without a stethoscope. That suggests some form of obstruction in his ear passage, right? There's some form of constriction occurring somewhere in his ear passage. So that's a general impression. Now that we have completed the general impression, what would be the next step, Mr. Jennings?
The next step would be to assess his level of consciousness and the ABCs.
Hold on. LOC would be next, yes? How would you ascertain the patient's level of consciousness? So I am the patient, communicate with me as you would in the field.
So within the field, assessing the patient level of consciousness, the first thing I would do is call to the patient to see if he can call back.
Do it. Don't tell me what you would do. Do it. I am the patient, communicate with me as you would with a patient in the field.
Hello, good afternoon, sir. Are you okay? Is everything all right?
No, I'm not doing good. I can't breathe. That's what the patient said to you.
Okay. Well, from
What have you
that,
hold on.
oh,
What have you ascertained from that response?
my patient is responsive. My patient is alert. and my patient is oriented because he understands what's going on and what's happening to him. So that's alert and oriented and very much responsive, as well as the difficulty breathing.
Okay. All right. So, do you know the name of your patient?
No, sir. So that'll be
Okay.
next.
So you need to find out the name of your patient. Hello, sir. My name is Ryan Rufus. I'm a medic. This is my partner, Mr. Khalil Barnett. What's your name, sir? Once you get the patient's name, okay, tell us what's going on with you, right? So remember, we need to ascertain long-term, intermediate, and short-term memory, right? So find out what your patient name is, find out what is wrong with the patient. Now, based on the patient's response, the patient is obviously having some difficulty breathing, however, is able to speak to you. So the upper airway is not too bad currently. So it would seem more like the patient is having a lower airway issue, right? Because he's able to speak to you. All right, now after you have checked level of consciousness, Miss Nesbitt, what would be the next step, the next phase or step?
Assess the airway and identify and treat any life threats.
And how would you do that? So I am the patient. Interact with me now and tell me what's gonna happen.
All right. So basically, what I would do, if the patient is sitting upright, then I would. If the patient is sitting upright and is comfortable in that position, as in it's easing its breathing,
Miss
then
Nesbitt,
huh?
do not tell me what you would do. Show me how you would do it. So I am the patient. You have introduced yourself to me. You have asked me what my name is. You have asked me what's going on. I tell you, I'm having some trouble breathing, right? I'm having difficulty breathing. How would you communicate with me after that information? And what is it that you need to do? That's how I want you to start thinking. So how would you communicate with me?
Well, Mr. Rufus, I am going to be checking.
Ah, good. So what would you be checking?
Sir, because airway and breathing is so close in this thing, I need to just concentrate on the airway, you said?
We have already assessed this patient's upper airway. His upper airway is patent. I already said that.
Oh, yeah.
The fact that he's communicating with you, his upper airway is fine, right? But while he's communicating, you know that he's pausing in between his speech to catch his breath. That suggests that there is a lower airway problem. So we need to now assess the lower airway. Yes, that's what we need to assess now. So after you ask the patient, you introduce yourself to the patient, you find out what the patient name is, and the patient tell you what's happening. Okay, Mr. Doe, I'm gonna be doing some checks on you, right? And we will provide treatment where we see that it's necessary, right? I'm gonna be doing some checks on you. And you start your checks. Now, what are you going to assess in the lower airway or breathing, Miss Nesbitt? What would you be assessing?
All right, so I would look at how his chest is rising and falling, and
Sequential. Well, on be sequential. So look at rate, rhythm,
I am going
quality.
to looking at the rate and the rhythm. I will also
Quality
be looking at
and depth.
quality and depth.
Right. So it's rate, rhythm, quality, and depth. Right? How would you ascertain the rate? Still with you, you know, Miss Nesbitt. How would you get this patient's breathing rate?
What I would do, I would rest my hand on his chest, and each time is he has a chest peak, I would count those, and within a 30-second period, I would multiply it by 2 and get his respiratory rate.
All right. So what I will say to you, for practicing, you can put that hand across the chest for a responsive patient. In the field, try and avoid that, right? So if you put your hand across my chest, I know that you're checking my breathing. I can alter it. If the patient is unresponsive, putting the hand across the chest is fine. When the patient is responsive, they can adjust their breathing pattern if they are aware of what you're doing. So what I will do when I am going to do the checks, I will take their forearm and put my fingers on the radial pulse, right? I'm not putting the arm across the chest, I'm just holding the forearm and the pulse as a distraction while I observe the chest rise and fall for 30 seconds and multiply it by 2. It will take practice to get accustomed to, right? But try and avoid putting the hands across the chest for a patient that's responsive. Now, the breathing rate that you obtain for this patient is 28 breaths per minute. So that's the rate. Miss Johnson, we have the rate. So it's rate, rhythm. What are we looking at with rhythm? When we look at rhythm, what are we looking at? What would you be observing this patient for if you're looking at rhythm? Go ahead, Miss Johnson. Where Miss Johnson gone?
Are you here,
issues?
sir? No.
Okay, so come on, talk to me. We have the rate. We're looking at the patient now. What are we looking for to determine rhythm?
To see if the chest rise and fall simultaneously.
That would be depth. Rhythm. What are we looking for in terms of rhythm? You want to try again? Want to try again, Miss Johnson? Don't overthink it. Okay, Mr. Jennings, rhythm, what are we looking for? Quickly.
Consistent.
I didn't
Hello?
hear that. Yeah.
We're looking for regularity, so we're looking to see if the rate is consistent. So where the breathing pattern is consistent.
We're looking for a consistent breathing pattern. Is it fast, slow, then fast, right? Or is it at a consistent pattern? Do you see a consistent pattern of breathing? So the patient is breathing at 28 breaths per minute. The rhythm is regular, so it's consistent. So that's rate, rhythm, quality. Ms. Nesbitt, what are we looking for in terms of quality? What we're looking for?
We're trying to determine if there the breath sounds, like if there's any normal breathing is silent. So we're trying to look out if we hear any gurgling sound, any is that it, sir?
Yes, abnormal lung sounds is one. What else we're looking for? So we're gonna be listening for lung sounds now. And when you listen to the patient's lungs, apex anterior, mid-axillary, and posterior, you're hearing wheezing on exhalation, both sides. So the patient has wheezing. That's the abnormal lung sound. What else would you look for in quality? So that's just sound. What else we're looking for in quality, Miss Nesbitt? Nothing else come to mind?
I'm thinking. Uh, quality. Quality. Sir, I'm always confusing it with amount, the amount of air.
Mm-mm.
I've gone into something else.
Yes, you're gone in something else. Miss Johnson, you want to try with the quality? So abnormal sounds, long sounds, yes. What else we
Yes,
can look
I
for?
found my notes. We can look if they're using other muscles, like the
Good.
muscles in the neck or
Right. You're
whatever.
looking for muscle use. You can see muscle use. So the patient is breathing at 28 breaths per minute. The rhythm is regular. There is wheezing bilaterally on expiration. You can see muscle use. So it's labeled. So it's abnormal lung sounds. Is it labeled and position? Somebody had mentioned something about tripod position. I think it was Miss Johnson. So when we're looking at quality, we're listening for breath sounds, we're looking for muscle use, we're looking at the position that the patient is in, right? So this is a patient presentation. Alert, oriented to person, place, time, and event with a breathing rate of 28 breaths per minute, regular rhythm, wheezing on exhalation, labored, tripod position, right? Tripod position. Now, the final thing we look at is depth, rate, rhythm, quality, and depth. Mr. Jennings, when we're looking at depth, what are we looking at?
When we're looking at that, we're looking at the amount of air that's being moved into the lungs, whether he has adequate chest rise and fall, and
Good.
yeah.
Good, that's it. You're looking for chest rise. Can you see visible chest rise, right? So the patient is alert, oriented, person, place, time, and event, obvious respiratory distress with a breathing rate of 28 breaths per minute, regular rhythm, right? So the rhythm is regular. The patient has wheezing on expiration bilaterally, muscle use, tripod position, but the patient has visible, so you can see visible chest rise. Now, I'm gonna ask all of you the question, the same question now. Miss Johnson, what would be your treatment based on the patient's presentation thus far? How would you treat the presentation so far? What would you do for this patient?
I would give them oxygen, sir.
Okay, so you're gonna give him oxygen via what? So you need to tell me the device and the flow rate. Oxygen via what? Which device?
Oxygen via a non-rebreathable mask, and
At
the rate would be four. No, sorry, we can't go over four. The rate would be 4 to 6 liters.
that wouldn't be a non-rebreather. That would be a nasal cannula. What's the flow rate for non-rebreather? You're mixing it up. So the nasal cannula is low flow. That's the low flow numbers you just gave me. High flow numbers would be what? You find a notes there yet, Miss Johnson?
No, sir, still looking.
All right. Mr. Jennings, what would be your treatment for the patient at this point?
Sir, I can be honest with you, based on the information that you gave and thinking about the patient, I would consider doing assisted ventilations via a bag valve mask with oxygen at maybe 15 liters per minute. But just to ask, I wonder, can you do something in a sequential order to see if the previous intervention first, such as adjusting the positions, providing it via a non-rebreather to see if that eases it, and then moving towards the bag valve mask?
Okay. So the BVM wouldn't be indicated for this patient. There's nothing in his presentation that suggests that a BVM is needed. Patient is talking to you. Patient is oriented. The patient is breathing at an elevated breathing rate. It is labored with visible chest rise. Visible chest rise, not poor chest rise. Visible. So there is nothing in the patient's presentation that would suggest that you can bag this patient. He's responsive. You think you can bag that patient responsive? He would not allow you to do that. Right?
So
He's not going to allow it. Yeah. The patient needs a non-rebreather. But what would be the flow rate that you use for a non-rebreather?
I would start at 10 and then go up depending on the oxygen saturation.
So that is reasonable. Start at 10, go up if necessary. Ms. Nesbitt, what would be your treatment?
That's the same thing I had. So I would be giving oxygen with the non-rebreather, and I'd do it at 10 to 15 liters per minute.
Okay. All right, good. So we're all on the same track. We know that the patient needs oxygen, but we have to determine how that oxygen will be given, right? And it either will be supplemented or positive pressure, right? Now, if I had said to you that the patient is becoming lethargic or sleepy and his breathing rate is 22 and severely labored, 22 severely labored with visible chest rise, but the pulse ox is less than 90%. Would you give this patient supplemental oxygen? Or would you prepare to bag the patient? Yes, Mr. Jennings.
Yeah, this is when you would prepare to bag the patient.
Right. Now, this is a patient you need to be prepared to bag because his mental status is changing and his breathing rate is coming down and he's still working hard to breathe. So that's a red flag. If you see a patient breathing rate coming down to normal levels and they're working very hard to breathe, it means that the compensating mechanism is no longer working. That patient will soon fail on you. So yes, you would need to prepare to bag that patient. Good. Excellent. All right, so we have put the patient on. No, there's something I forgot to mention. Once you have a pulse ox on your unit, before you put your patient on oxygen, find out what the pulse ox reading is on room air first, right? So between 90 and 93%, you can use your low flow device. Anything below 90 with signs of hypoxia, the patient requires high flow, right? So find out what the pulse ox is on the room air before you put the patient on oxygen. So our patient is on a non-rebreather at 10 liters per minute, high flow oxygen. So that's assess and manage breathing. What is next? So Miss Johnson, where would we move on to assess next? We have checked LOC, we have assessed the upper airway, we have assessed the lower airway. What would be next?
We take a history, sir.
Nope, nope. We are
No.
at LOC, upper airway breathing. What is next? What is next?
Assess circulation.
Circulation would be next. Circulation would be next. So we have assessed the patient's breathing. We recognize that something was wrong with the breathing. And if something was wrong with the breathing, it's possible that it may have affected circulation. So we need to assess the circulatory system. So assess circulation. All right, now, Ms. Johnson, what are the things that we assess in circulation? What are the things that we would assess in circulation?
So we would check the pulse.
Pulse. This patient is responsive. Which pulse would you check? Would you check the peripheral pulse or the central pulse? The patient is responsive. Which pulse would you check?
The peripheral one, the one down by the radial artery.
Okay, you are correct. You would check the radial pulse. Excellent. May I put pressure upon it today? Hold on. So you go. That's how we will learn. Mr. Jennings, when we evaluate the pulse, what are the things that we check the pulse for?
We check the pulse for the rate. We check the
Rate,
pulse for rhythm. And we
rhythm,
check the pulse for quality.
quality, or strength. Good. Ms. Nesbeth, how do we obtain a pulse rate?
You would basically the index finger and the middle finger, you put them together and you press firmly on the radial pulse in this case, and you count for 30 seconds, and you note the what you call the beats per minute. If you realize that it is irregular, then you have to do the full minute.
Okay, I hear bits and pieces, but I think you're on the right path. So you palpate the radial pulse with 2 fingers or 3 fingers. You can count it for 15 seconds and multiply by 4. You can count it for 30 seconds and multiply by 2. If it's irregular, you count it for a full minute. So that's the rate. Miss Johnson, what are we checking for the rhythm? So when you palpate the pulse, what are you checking for the rhythm?
We're checking to see consistency.
Good. Consistency. You better learn that word then. Consistency. So you want to see if it speeds up, slow down, or is there a constant or regular rhythm, right? So the patient has a pulse rate of 110. It is regular, right? Mr. Jennings, what are we checking for in strength? What are we checking?
We're checking whether it's weak, we're checking whether it's steady, and we're checking whether it's bounding.
Good. The patient has a pulse rate of 110. It is regular bilaterally, but it is weak. And that's the radial. The rate was obtained on the right radial. So that's pulse. Ms. Johnson, what else would we be looking at in circulation?
Sir?
What else would we be looking at besides the pulse in circulation?
We will look at the skin condition.
Skin condition. Ms. Nesbitt, what are the things that we will look for in the skin condition?
The skin color, the skin temperature, and the skin moisture.
Good. So that's color, temperature, hydration. Good. Okay. Where would we look for skin color changes? Mr. Jennings.
You can look for skin color changes under the nail beds. You can also look for it by the lips, and you can also look at the little pink membrane in the eyelids.
Okay. All right. So you always start peripherally. So you look at the palms, patient palms, and if you see any changes that are abnormal peripherally, you check for it centrally, either in the mucous membranes of the eyelid or mucous membranes in the mouth. Now, when you check the patient's palms, the patient has peripheral cyanosis. So there is cyanosis at the palms. When you check for it centrally, it is not there. So there is no cyanosis centrally. Miss Johnson, how would you check temperature at this point?
I would use a thermometer.
Okay. Now, in the primary assessment phase, we don't need an actual thermometer reading at this point. We would need that when we're doing our baseline vitals, right? At this point, we're trying to determine if the patient is going into shock. So all you need to quickly do is just put the back of your hand on the patient's forehead or core of the body to see if they feel cooler and clammy, warm and dry, or excessively hot, right? We don't need an exact temperature reading at this point. So the patient has a pulse rate of 110, regular, weak, bilaterally. The patient has peripheral cyanosis, doesn't have cyanosis centrally, and the patient is cool and clammy. Is there anything else you would do at this point in your management, Ms. Nesbitt? So based on the patient's findings so far, would you do anything different in your management? Hold on, Mr. Jennings. Ms. Nesbitt, would you do anything differently?
No, sir.
Okay. You sure?
Can you clarify differently? Are you asking if I would move to the other step? That's what you're asking?
No. I'm asking if you would adjust any of your management at this point based on the circulation findings.
Well, I could reassess the. Sir, I don't know.
Okay. All right, Mr. Jennings, go.
Well, so I actually want to just ask you a question. Seeing how the skin is an organ and is fully intact, would basically like how you would have the diversion of blood for regions. Would the skin temperature be consistent all over the body? How you say that you can check the forehead and the, because I'm wondering if putting the back of your
No,
hand on.
point that I mentioned, forehead, and the core, trunk region. So I'm checking the skin in a central point, not a peripheral. So that is sufficient to tell you the temperature of the skin at that point. Right?
Okay,
So
okay.
I don't check a patient's temperature by touching the hand. I go to the core or the center of the body. So it's either the forehead or the chest. That's where I'll put the back of my hand.
Okay, okay.
Right?
That makes sense. That
Okay?
makes sense.
Good.
And to answer the question, based on the presentation, you would consider thermal management since the patient is cool and has pale skin.
Right, you can consider to maintain body heat. You can also consider to move from 10 liters to 12 liters now. We start off at 10, yes. Yes, we can start to go up to 12 liters. Why? Because our patient is starting to show signs of shock.
Right.
Right? So you can start to increase your oxygen management. Now, this is the patient's ABCs. We have completed the ABCs. We need to now ask ourselves several questions. So the first question would be, what is the patient's GCS? Based on the presentation, patient GCS would be 15. Eye opening, verbal, and motor response would get full marks for that. So the patient would have a GCS of 15. Do we need to do a rapid scan or focus assessment on this patient? Miss Nesbeth, do I need to do a rapid scan or focus?
Focus, sir.
Good. So I would focus on the respiratory system and the cardiovascular system. Miss Johnson, is this a stay and play or load and go patient?
Load and go, sir.
Load and go. So we have answered all of the questions. We know what the patient's GCS is, right? Patient has a GCS of 15. We will focus on the respiratory and cardiovascular system, and we need to package this patient for transport and move as quickly as possible. Load and go. So we would have completed the primary assessment at that stage. Yes, Ms. Nesbeth, go ahead.
Sir, how would you do a focused assessment in this case? Like what you would do?
We're going to repeat what we have done already, and that would come in your secondary assessment. So you're going to keep reevaluating the patient's breathing rate. You're going to look at the chest more closely, make sure that you can see symmetry of the chest, make sure there is no ear under the skin. You're going to listen to lung sounds again, and you can be more detailed with your lung sounds initially. You may have done 4-point auscultation. Now you can do 6-point auscultation. You're gonna listen to the heart rate. So it's a more detailed assessment. It's the same thing that you did before, but you're spending time now to do it more carefully, right? That's how it would work. So GCS, coming Ms. Johnson, GCS, focus, rapid transport. Yes, Ms. Johnson, go ahead.
So, sir, whenever we introduced ourselves the first time, I wish I will ask the person what is happening. What if the person told us exactly what was happening to them? Don't take that into consideration.
Of course, you take it into consideration.
Okay, but we still do the assessment just the same.
Yes, yes, you have to do your assessment. Why? Because we cannot treat what we have not assessed properly, right? So if we don't assess something properly, we can't treat it. Yes, Miss Nesbeth.
Sir, I think I am a little confused at this point, because in the primary assessment, you can do either a rapid exam, you say, or a focused exam, right?
Yep.
Right. So the rapid exam, sorry, in this case, you're saying that just the focus exam would be really what we're doing in the secondary assessment? That's what you're saying?
Yep, because the patient can tell us what's happening. If this patient was not able to tell you what's happening, then you would do a rapid in your primary.
Skip the rapid. Skip that entire set of stuff. That's what you're saying. You know, we would skip this.
No, let me clear it up. So if you have completed up to circulation, you know what your patient's GCS is, right? At this point, you will either move your focus from your secondary assessment to your primary, or you will do a rapid scan. Now, if we do a focus at this point, I'm actually moving a part of my secondary assessment into my primary based on the patient's ability to tell me what's happening and what I've observed. I don't know if you understand what I just said. You get what I'm saying?
Just understanding. So if the patient is not responsive and you really cannot determine a MOI or a MRNOI, that is when you do the rapid thing, or if the thing is the MOI is diffused, that's when you do the rapid body exam.
That's correct. That is correct. So that's when you would do a rapid. But this patient can tell us all that is happening. So we can simply focus on the presenting problem. And right now what we're seeing is that the respiratory system and the cardiovascular system is affected. So our treatment will be centered around that, right? And because of the presentation, we know that we can't stay and play with this patient because we heard wheezing, so the patient has bronchoconstriction, right? So it's a load and go rapid transport. So we have completed the primary assessment, right? And we won't go any further than that today. The next phase would be history taking, secondary, and reassessment, right? Yes, Ms. Johnson.
Sir?
Yes.
I keep hearing you talk about GCS, but
Glasgow Coma Scale.
did you tell us how to calculate it? I don't remember, or I wasn't in that class or something. I don't know.
I don't know, but it's a part of patient assessment, right?
Okay.
So it evaluates 3 areas: eye opening, verbal response, motor response, EVM. Most the patient can get for eye opening is 4. The most the patient can get for verbal response is 5. And the most they can get for motor response is 6. Read up on it. For me to explain it to you, I would have to have the chart to show you the calculation, and I don't have that right now. So if I go through explaining it, it's not going to make much sense. So look it up in your book. If you don't find it in the slides, Google it, right? So the maximum the patient can get is 15. The least would be 3. But GCS. So GCS is a more accepted way of assessing a patient's, is a more universally known method for assessing a patient's level of consciousness, right? So that scene size upon primary for a patient that's responsive with good chest rise. Was it difficult or was it manageable? Ms. Nesbitt.
It was a bit challenging for me because it's the first time and I didn't know about the GCS because it was not in the textbook.
The textbook or the slides?
I don't see it in primary assessment in the textbook, sir.
It's in patient assessment. I can guarantee you that at GCS is in patient assessment. So go back and check. Yes, Miss Johnson.
It's on page 364.
Yes, I know it's in there. I know it's in there. So, patient assessment. GCS is in patient assessment. It's a part of it. Don't worry about how challenging it is. It's the first time that you're being introduced to this approach, which is a sequential way of assessing a patient, right? So it's going to take time for you to get used to it, but this is how I want you to be thinking. So when I ask you about, when you mention to me that the first thing you're going to do is size up the scene, you need to tell me what you're looking for. Okay, sir, need to make sure that the scene is safe. Going to be considering the MOI or NOI. I'm going to be taking standard precautions for myself, my partner, based on the information so far, one patient, and I'm going to request ALS for this patient. That's a scene size up. When you go into your primary assessment, you need to be able to tell me what it is that you're going to be doing in your primary assessment. Okay, sir, I'm going to be forming a general impression of the patient and the environment. I'm going to be assessing the patient's level of consciousness and assess and manage airway breathing, circulation, determine GCS, the need for rapid scan or focus, and the need for rapid transport or stay and play. And then you make contact with your patient. So when you start to write it out, how would you check the LOC? I would introduce myself to the patient, find out what the patient's name is, and ask the patient to tell me what is happening to him. Based on his response, I will be able to determine if the upper airway is patent. The upper airway is patent, I will instruct the patient, okay, sir, I'm going to be doing some checks on you. And then I would evaluate breathing, starting with the rate, rhythm, quality, and depth. If there is any abnormal findings, I will treat using supplemental oxygen or positive pressure ventilation with high flow oxygen. After addressing the patient's breathing issues, I would next assess circulation. There's no need to look for external bleeding, so I would focus on checking the pulse for rate, rhythm, and quality, or rate, rhythm, and strength. Based on the findings, I would be able to determine if this patient is going into shock, and I would adjust my management accordingly. At this point, I would know the patient's GCS, which is, patient is definitely a load and go, and I am going to be focusing on the respiratory and cardiovascular system. So that's how I want you to start thinking. Start thinking that way, that when I catch you in person, it's not difficult for you to do it in person. Start to think that way, right? So for the next class, we will look at how we would obtain the history from the patient, and the vital signs, and we'll talk about the reassessment. All right, so we're at week 3. How do we feel at this point? Is it starting to get challenging? Starting to feel pressured? Remember, diamonds are made under pressure, you know. So it's either we're gonna get diamonds or the pipe bursts. So Mr. Jennings, after 3 weeks, how we stay?
I'm feeling pretty good, you know. Really and truly, I like the restructuring and the more structured approach. I think that it definitely makes for a better assessment. Information wise, there's a lot of things that are definitely new to that I've never taught or heard about, like in conversation with other people.
Okay.
This is very good. I'm happy about this.
All right, cool. Work in progress. Work in progress. Miss Nesbeth, always worrying. Always stay.
Well, I'm here to determine if the pipe will burst or if I'll be a diamond. So far it has been really good. It's just a lot of reading and work and balancing out stuff. But so far, so good.
All right, no problem. Work in progress, work in progress. Miss Johnson, always there.
Going on, sir.
We're going
There,
on. All right.
yeah, there's a lot of reading, and I don't think I can remember all the definitions. So
You, you will. You will. And you can. Right? So it's work in progress. As we go on further, yes, it will become a little bit more challenging, but it's gonna get easier. Because everything I'm doing now, we will constantly repeat it until it becomes second nature to you. Right? That's the goal. All right. I think that is it. Somebody have a question? Miss Nesbeth, you have something you want to say?
Yes, sir. I was asking about the exam on this coming weekend, right, sir?
What about the exam?
Coming week, sir? Wednesday,
Ye-
Thursday, and Friday.
yes, quite so.
So, sir, you don't think they could be spaced out a little more?
No, I should be giving you all three exams in 24 hours, but I am spacing them out. So
Okay.
you will be fine. Just make sure that you put in the work, right? Put in the work and you'll get the results that you want. It can be done, right? So each of these exams will have probably about 25 questions. So you're gonna get about 25 questions for primary assessment, sorry, for patient assessment, 25 questions on shock, maybe 30 or 25 on airway, right? Put in the work, just put in the work. It will work out, must. Yes, Miss Johnson.
in what order will they come, sir?
What do you mean what order? The first
Which
one is
exam?
the first exam would be primary patient assessment, because that was the first chapter that we covered. Then the second would be airway management, and the third exam is going to be shock. So it's going to be in that order. Yes, Miss Johnson.
So you said the third exam is going to be shock, sir. So we are going to be shocked at the exam. That's what you mean?
No, I'm talking about shock hypoperfusion. That's what I'm talking about, not shock, as in you can't believe that the exam was so difficult, right? So you people will be okay. Anyway, that's it for today. I will see you on Tuesday. Enjoy the rest of your day and your weekend.
Thanks,
Right?
sir.
Thank you, sir.